Thank you. Preparing and demystifying MRCPI and clarity on COPD and asthma. My name is Dr. Ahmad Basirat, and I'll be your mentor with med exam expert for the MRCPI. I've been working in Ireland since good few many years now, and I have good few experience, in MRCPI. Okay, so this is the Royal College of Physicians of Ireland. This is the main building, which is in Dublin. Probably will say in the heart of Dublin, and you can see that this is from outside, and the next picture you can see this from inside. This really is a great place to visit, and of course, this is you guys should be aiming for getting your conferring ceremony one day in this building. So this is the main entrance, and you can see the big staircase. Okay, so let's go to MRCPI roadmap. There are three parts of the exam. The colors in blue, I probably can use a pen here to kind of make it a little bit more easier. So this is the MRCPI Part 1 written examination. If you pass it, you move towards Part 2 written examination. If unfortunately for any reason you don't pass it, you have total 6 attempts to give your Part 1 exam. And I will explain it to you later on a little bit more that there are no further attempts allowed after the 6th attempt. If you pass the Part 1 exam, you move towards the Part 2 written exam. And then, of course, if you pass it, then you go towards the Part 2 clinical exam, which is also called the OSCE. Now, if you don't pass it, the Part 2 written exam, you then again get 6 attempts to go for the Part 2 examination. And of course, if you pass it, then you move towards clinical. In the clinical exam, you pass it, then you go towards, this is the main goal, to sit in the MRCPI conferring ceremony. And if you don't pass the clinical exam in the first attempt, you still have 6 attempts to give the exam. And then further on, it says no further attempts allowed after the 6th attempt. So really, you have a lot of information in this particular slide. So this is kind of like the staircase. You move from Part 1 written towards Part 2 written, and then Part 2 clinical or OSCE examination, and hence then you move towards the final goal, which is the MRCPI conferring ceremony. So sitting in the MRCPI examination will be allowed. So the candidates who are sitting in the MRCPI general examination will be allowed a maximum of 6 attempts for each component. So in total, there are 18 attempts. There is a time limit under which a candidate must complete the Part 2 written and Part 2 clinical exam. So as you can see, Part 1 has 6 attempts, maximum number of attempts. And of course, it says time limit to pass is unlimited because obviously there's no time limit to sit in the Part 1 written exam. Then Part 2, you have like 6 attempts to pass Part 2 written. And there is a time limit to pass Part 2 written, and this is basically 6 years from the time when you have passed your Part 1 written examination. And then you move to your Part 2 clinical exam. It again has 6 attempts to pass it, and the time limit to pass is 3 years from the time you have passed the Part 2 written examination. A candidate must pass the Part 2 written examination within 6 years of passing the Part 1 exam. If a candidate has attempts remaining for the Part 2 written exam, but the 6-year time has expired, a candidate must resit and pass the Part 1 before attempting the Part 2. So it basically says here is that if the candidate has passed the Part 2 written, but the 6 years time has expired, then you can't go towards the clinical part. You have to give the clinical Part 1. You have to give the Part 1 written examination, again, and then you have to start the staircase again. So this is the information I want to convey. Okay, so entry requirements. So you probably are wondering how should we enter, or how are we eligible to sit for the Part 1 exam? So candidates for the MRCPI General Part 1 exam are eligible to apply 6 months after they have received their primary medical degree. So basically, whenever you have passed your MBBS or MD or whichever country you have passed your medical degree, so 6 months from that time onwards, you can apply for the Part 1 exam. Candidates must have passed MRCPI Part 1 General Medical Exam, a General Medical Exam, or Part 1 Pediatric Examination, or have obtained an exemption. I will tell you later on what the exemption criteria is in order to sit for the MRCPI Part 2 General Medical Written Examination. Candidates must have passed the Part 2 General Written exam before applying to enter the Part 2 clinical exam, unless they have been granted an exemption. So there is an exemption, it will come later on, in which a candidate can directly sit into the Part 2 clinical examination. Okay, so the exemption criteria for Part 1 is only if you have completed your MRCP UK, all three components, or there's a list of other exams as well, such as you have completed MRC PATH, MRC PCH, FRACP, FRCP, or if you have qualified from the Arab boards in general in GIM and pediatrics, from the Saudi boards in GIM and pediatrics, Kuwait boards of medical medicine and pediatrics, Oman medical specialty board in medicine and pediatrics, and if you have done FCPS in medicine and pediatrics from Pakistan. So if you have completed your FCPS in medicine or FCPS in pediatrics, you can get an exemption, or you can apply for an exemption for the MRCPI Part 1 only. That means that you still have to give the MRCP Part 2 written and of course clinical examination to get the whole MRCPI degree. And then the exemption for the MRCPI Part 2 examination, Part 2 written, not the clinical, Part 2 written, is FRACP. So if you have FRACP, you can get exemption from the Part 2 written, which means that you only have to give the Part 2 clinical examination to get the MRCPI. Candidates claiming exemption must include an attested certified proof of this qualification with their application. And then there's a list of list from where you can get the qualification approved from. This is basically one of the issuing university or medical school, or solicitor, notary public, commissioner for oaths, Irish or British consulate, your own embassy or higher commissioner, and including your the Garda is basically called the police services in Ireland. So okay, so where is this exam location? So how is it conducted? So where do you since COVID, this has basically really changed the shape, in how you guys can give the exam. So it's basically a remote invigilation by which you can appear in your Part 1 written and then Part 2 written exam. So MRCPI General Medicine written examinations are delivered by remote invigilation through our online exam provider called Test Reach. So this is an external, I would say, company through which the exams are conducted. Remote invigilation allows a candidate to sit the computer-based exam from their own computer, for example, at home or at work. I remember there was a time when the Part 1 written was computer-based, but you actually had to go to a place. Like I personally went to the RCPI building in order to appear in the Part 1 exam. So but now you are able to appear in this exam from your own home or at work or wherever you are sitting in a comfortable place. You can actually appear for it, which actually has it actually has reshaped the whole scenario around which people can appear for the exams nowadays. Candidates are supervised remotely by invigilators, supervisors throughout the exam. And candidates are required to adhere to the following requirements to sit an exam by remote invigilation. So, of course, like it's understandable that you need a quiet, secure environment, a room where candidate can take the exam, a room which you have exclusive access, obviously single occupancy, a room that does not have integrity security cameras. A candidate is confident that he will not be disturbed during examination. That you only need a PC or a laptop computer, not a mobile phone, of course, a PC or laptop computer with a reliable internet connection, webcam and microphone, and you can appear in the written examination, which include the part 1 and part 2 written exam. After conducting the validation checks with the supervisor, candidates must switch their mobile phones off and put it out of reach. Other than that, candidates should read the test reach candidate FAQ section, which they do circulate before the exam, and it gives you a good bit of detail what the requirement is. And the general medical, and as far as the clinical exam is concerned, of course, clinical exam needs a venue to take place. In Ireland, it is delivered as well as it is delivered internationally. I will tell you that in international locations of the clinical exam where they take place, the exam centers are listed on the website. Okay, so let's move on to the MRCPI part 1 spread of questions, which is basically very important. And this is very important to understand that how they have actually divided the questions topic-wise. So if you actually look at this first, so the main sections are the ones which have 5 to 15 questions, which will come in the exam. So let's move the screen here a little bit there. Okay, so I will start from cardiology. I will start with the basics first. So anatomy, microbiology, biochemistry, ethics, genetics, these all form like of one topic in general, in with like 5 to 15 questions will come out of these all little small topics. Okay, cardiovascular then is quite important. 5 to 15 questions from this topic, from CVS or cardiovascular. So really the main, I would say, thing. So if you so this is one, then move on to cardiology. This is another one. We'll come back to dermatology. Then we go to endocrinology. So endocrinology is also 5 to 15 questions. So the main chunk of questions are from these topics, if you see these. So from the basics, anatomy, microbiology, biochemistry, genetics, immunology, metabolic, physiology. Then we go to cardiovascular, endocrinology, gastroenterology, hematology, nephrology, neurology. Okay, then we go to respiratory medicine, which of course is very important and bit tricky as well. Rheumatology, and then pharmacology. So these are the main kind of topics from where these question back the whole kind of exam is set from. The minor topics include dermatology, infectious disease, ophthalmology. They're really like small topics, but the main chunk are the ones which I've circled. So one paper is part 1 is of one paper which has 100 MCQs. It's 3 hours of duration. It is delivered by remote invigilation. It has no negative marking. So there's no negative marking. Each question, each MCQ carries equal marks. At least 75% of the questions will involve direct clinical care of inpatients and outpatients. So it's really a clinical exam in the sense that all the MCQs are clinical scenarios, as you will appreciate when we go towards the preparing of the exam and later on, that each question involves mostly a patient who actually it will look like the patient is actually entering your outpatient's room, or you're actually going to see a patient in a ward, or so it's really like a clinical environment in the questions are designed. And correct answers will be within the up-to-date guidelines. So each year, I would say the new guidelines do come up, of course, and all the correct answers are within those up-to-date guidelines, which of course we will discuss once we start the preparatory course. MRCPI part 2 then written, the spread of questions in regards to the part 2 written. The main topics again, cardiology, 10%, respiratory endocrinology, 10% GI, 10% hematology, 10% neurology, 10%, nephrology, respiratory, rheumatology. So the minor ones here are infectious disease, dermatology, oncology, and therapeutics and toxicology. So again, the main chunk of the questions, as you can see, is not a big difference from part 1 and part 2 written. That if a good preparation of part 2, I'm confident to say that you do a less more work in order to prepare the part 2 written exam, and you become successful. So part 2 written is different because it has 2 papers. Each paper has 75 MCQs in it. Each paper is 2.5 hours long. So the part 1 written was 100 MCQs, 3 hours. Part 2 is 2 papers. Each paper is 75 MCQs, 2.5 hours. It's also delivered by remote invigilation. There's no negative marking. Questions may include, so this is some difference that in part 2 written, the exam includes, the question paper includes some photographs, some data interpretation, some retinal photographs as well. So there's a little bit difference from the part 1 written. The combined mark of part 2 written is 150, and it's not required to pass both papers in order to pass. So both papers are taken as a collective in order to make a total mark. Okay, so moving towards part 2 clinical. So part 2 clinical is the final examination which must be completed to be eligible to conferred as a member of RCPI. And the part 2 exam assesses a candidate's clinical skills, for example, ability to take a history, perform clinical exam, and formulate investigations and management plans. So it's really like a full combination. If you put it like so they basically, sorry, if you can mute your mic, can you mute your mic in the background? Sorry.
Myself. Am I audible, sir?
Sorry, can you mute your mic, please?
Yeah, 1 minute.
Thank you. Thank you. So part 2 clinical exam assesses a candidate's clinical skills, for example, ability to take a history, perform clinical exam, and formulate investigation and a management plan. The clinical examination consists of 2 long cases and 5 short cases. So they're 2 long and 5 short cases. So 2 long, 5 short cases will have approximately 2 hours to complete the whole examination. The long cases, I'll just quickly go through these things. So the long cases require candidates to examine 2 patients, 25 minutes each. Okay. Each station, the candidates will be observed for 20 minutes while they take a clinical history and perform a clinical examination as directed by the examiner. The candidates will present a summary of active problems and differential diagnosis. The final 5 minutes of the examination will be dedicated to discuss the investigations and management of patients' overall clinical problems and aftercare. And of course, the candidate's ability to communicate will be tested throughout the station by the observed history-taking interaction with the patient and your ability to clearly communicate with the examiner. The 5 short cases, candidates will be examined by 5 independent examiners, 1 in each station for 10 minutes each, or on their ability to elicit and interpret physical signs in various clinical systems. There are 2 types of short cases. So clinical cases, communication. So there will be 4, normally, routinely, there are 4 clinical cases and 1 is a station for communication and ethics. So typically there will be 4 clinical cases and 1 communication skills or ethics case. Part 2 clinical cases normally include, or routinely, I would say, include patients with medical conditions from the following systems. So that's the main gist of it. So cardiology case, respiratory, abdominal, endocrinology, dermatology, not that common, but can come, neurology, yes, and rheumatology. So mostly what happens is they give like 1 cardiology case, so they normally combine cardiology with respiratory. So they give 1 cardiology or respiratory. Okay, so that makes 1 station. Abdominal is yes, so that probably is 2nd station. Endocrinology, yes, it probably is the 3rd station. And then rheumatology or neurology, they give like the 4th station. So these make the 4 short cases. Sorry. And then 1 is, of course, the communications case, which is the ethics case, which is always as a separate. So communications or ethics scale, each communication or ethics case will last 10 minutes. And it's basically a 6 minutes interaction with the patient and then a 4-minute discussion. The candidates will be expected to interact with the simulated patient. So they're all simulated patients and they're very good simulated person sitting in front of you. And then, it's not a real patient, but of course they're simulated patients. The candidates will be provided with the written instructions summarizing the case before he enters into the room for the clinic for this ethical case. Each case will be examined by one examiner, and the cases will include the communication scenarios relating to either discussing a treatment option with the patient, or breaking bad news, or taking a consent for a procedure, or taking a consent for treatment from a patient with mild cognitive impairment. Then some confidentiality, for example, maintaining confidentiality under pressure from a family member. This is very common. Managing challenging situations, for example, discussing organ donation with next of kin. So you need to kind of know the ins and outs of these all main scenarios, which of course will come when we go towards preparing for the exam. But this is just to give you an overview that what kind of clinical, cases can appear in the communication station. Candidates should prepare, and this is just a list of recommendations from the RCPI that the candidates can prepare from the following courses, like leadership course, breaking bad news, guide to professional conduct and ethics, good medical practice, and this is like a website link in order to prepare for the ethics case. You guys probably are wondering, obviously, about the examination fee and, of course, like visa if required. So the examination fee, of course, is decided by RCPI, and it's available to see online on their website. Candidates will be permitted to take the examination only when the fees are paid in full. If a candidate requires visa to sit for an examination, of course, if you want to sit for you have to sit for the clinical examination, which happens in Ireland or overseas internationally. If they require a visa, then it's the responsibility of the candidate to ensure the visa application is made in sufficient time before the examination date for which it has to be sought. A refund will not be given if a candidate is unable to attend the examination as a result of a visa-related problem. This table just want to show you guys that there are 3 dates each year which come for the part 1 exam. Let's say, for example, this year it came in January. Next date is coming in April, and then there is one coming in August, right? And this exam fee is the same from wherever you apply in the world. So because this is an online exam, so it's 710 euros. You probably can convert into your own country, whichever currency you guys are using. So this is a set fee for the exam. There's an opening date to apply, and then of course there's a closing date. And I think this is not a matter of I'm not 100% confident, but I think you can probably apply very close to closing date as well, because this is an online exam, so they probably can accommodate as much as possible. And then there's a provisional result date as well. Part 2 exam again happens 3 times a year. March, for example, this year it's in March, then it's in July, and then it's in October. And the exam fee is same for each year, 730 euros. So you can see this is exactly the same for each year because it's an online exam. Then we go to the part 2 clinical. Part 2 clinical actually also happens most of the time happens 3 times a year. So they give you an exact date later on where and what date your exam is, but the slot is normally, so this year it was January to February, then the next one is coming in May to June, and then it will come in September to October. The exam fee here varies. If you are sitting in Ireland, it's 845 euros. But if you're sitting in international locations, which are MRCPI, clinical international locations, so there's a little bit higher fee. I'm not 100% sure how much is it, but a little bit more than this. You can check it from the RCPI website. So these are the international locations where you can sit the clinical exam. So it's in Saudi Arabia, in Jeddah and Riyadh. Then it's Oman, then in Malaysia, in Kuala Lumpur, UAE, Bahrain, and again in Malaysia, in Shanghai as well. Okay, so how will we deliver our exam preparatory course in conjunction with Med Exam Expert? So I will do a very exam oriented and targeted course because at the moment we are aiming for the part 1 MRCPI diet, which is coming in August. So what we will do is I will be delivering it via lectures, topic and chapter wise. Each lecture will be of up to a max of up to a duration of 3 hours. There will be live Q&A sessions. MCQ in conjunction to these lectures, there will be MCQ daily and weekly sessions on Telegram or WhatsApp where you will be able to communicate with myself. I will introduce some flashcards for the quick exam revision, which I think will be very helpful for you guys, because I've been actually teaching in person as well in my hospital and in my career to the candidates who are appearing for the MRCPI, and of course these include international people coming from all over the world to come to work in Ireland, and of course graduates from Asian countries and European countries. And support and guidance, of course, will be available to you guys as much as I can guide you in order to help you to ace your part 1 upcoming exam in August, and hence you can step up towards the part 2 written. Some pitfalls, this is my general kind of thinking why people fail in the exam. One is poor time management. Time management is generally very important in your life anyway, which I believe, but I think if you have poor time management in the exam, it's one of the big reasons of not passing it. Taking too much time on a single question, lack of revision. Revision is the key to pass any exam, and I think it's very important to keep revising the course. Not simplifying the last 1 to 2 weeks before the exam date. You need to go into an exam mode 1 to 2 weeks before the exam in order to pass the exam. Lack of confidence, scoring less than 50 to 60% on the mock exams. Poor night's sleep before exam is also one of the major factors. Not paying close attention to the question stem. So you need to pay very close attention to the question, because these wordings like initial, most, not a likely, cause, first step in management, accept, these are very important lines and words you need to pay close attention to when you're answering a question. Okay, so that was all about MRCPI in general. I wanted to talk to you about COPD and asthma. It's a very important topic, and it is a very important topic in respiratory medicine. Include a lot of questions in the exam as well, and candidates often find it quite difficult and tricky, but I will give you a little bit of overview about this, and will hope that will make your life easy in order to understand what these two things are. So asthma versus COPD. So let's talk about the main differences between asthma and COPD. So we talk about we start from the age of onset. So if you look at asthma, it's often childhood, although it can manifest after the age of 40. COPD typically after the age of 40. So really you can see the age of onset, okay? We talk about causes, allergic and non-allergic. So asthma can be allergic, it can be non-allergic. COPD, 90%, not 100%, 90% of the time, cigarette course with some ups and downs, so episodic attacks, whereas COPD is like insidious course, it's insidious, like gradual and chronic progression over years, okay? Chronic productive cough is not common in asthma, whereas it's very common in COPD. So I would say productive cough Uncommon in asthma, but very common in COPD. Diurnal variation, which is the day-to-day variation, it's very common in asthma, uncommon in COPD. Nighttime waking with breathlessness, very common in asthma, uncommon in COPD. So as we're going along, these are mainly the history questions as well, and these are the things which you have to look in the exam, in the MCQ scenarios. Atopic symptoms, allergy symptoms, very common in asthma, uncommon in COPD. Obstruction. This is seen on the pulmonary function test. I'll show you some later on. Asthma is reversible. What does that mean? It means if you give bronchodilator while doing PFTs, the FEV1 increase to more and above 12%. It should actually write here 200 mils as well. So it's 12% and 200 mils difference in FEV1 post bronchodilation, right? Whereas COPD is persistent airflow limitation, that is post bronchodilator, FEV1 over FVC ratio does not go above 70%. It says less than 70%, doesn't change, because this is a fixed airway disease, right? This is fixed airway disease. A little bit difficult to write with this pen here, but whereas asthma is variable. Treatment-wise, inhaled corticosteroids, first-line medication, whereas here, long-term bronchodilators are the first-line medication. So, and just one note that patients can have both asthma and COPD as well, as opposed to having either of them. Very important table in exam, very important table in exam to remember, because all the pulmonary function test is based upon remembering this table. So classification, both asthma and COPD, you can have mild, moderate, severe, very severe. All of these will have FEV1 over FVC ratio. Just remember this, FEV1 over FVC ratio of less than 0.7. All of these classes. How will we differentiate? Just with the FEV1, okay? So mild will have more than equal and more than equal to 80%, right? Moderate will have 50 to 80%. Severe will have 30 to 50%. Very severe, less than 30%. So easy. 80 and above, mild. 50 to 80, moderate. 30 to 50, severe. Less than 30, very severe. So easy. So mild, moderate, severe, very severe. COPD follows GOLD criteria, okay? So there's an internationally recognized criteria which are GOLD, okay? So GOLD criteria has 3 classes, A, B, and E, right? Why is this important? Because this actually decides the treatment, okay? So once you have come to the diagnosis that this is COPD, you go to actually classify it. Either it is GOLD A, GOLD B, GOLD E, and this is as per their MMRC score, which is the symptom score. And then here you go with the exacerbations. So if you have 0 to 1 exacerbation or flare up, and you have MMRC score of 0 to 1, it's GOLD A. Similarly, if you have MMRC score of 2 or above and 0 to 1 exacerbation is GOLD B. And if you have 2 or more than 2 exacerbations or more than 1 hospitalization, so if you can see, it's a little bit of, so this is hospitalization. This is only exacerbation. So if more than 2 exacerbation or more than 1 hospitalization, you go to GOLD E. Okay, so this is important. So this is a very important table in to remember in the exam. So COPD, NICE, which is the UK-based guidelines, recommend considering a diagnosis of COPD in patients over 35 years of age who are smokers or ex-smokers and have symptoms such as they are breathless, or they have chronic cough, or they have regular sputum production. The following investigations are recommended in patients with suspected COPD. Number 1, we do the pulmonary function test. They have FEV1 over FVC ratio of less than 0.7 or 70%. So that means that they have airflow obstruction. Chest X-ray, it shows hyperinflation. They have hyperinflation, flat diaphragms. Sometimes you can see the bulla as well. Full blood count, you check their blood, they show hemoglobin, which is raised, okay? And that basically points towards having secondary polycythemia. Body mass index calculation, and then severity of COPD is categorized using the FEV1. This is very important. as I've told you earlier. So FEV1 value alone is used to grade the severity of COPD once the diagnosis is established, but it is not the part of diagnostic criteria. So it is not the part of diagnostic criteria. It is only used to grade the severity of COPD. So it's mild, moderate, severe, very severe. Okay, so going towards asthma, we follow 𝐏𝐫𝐞𝐩𝐚𝐫 guidelines. Okay, so 𝐏𝐫𝐞𝐩𝐚𝐫 guidelines actually tell us how to treat asthma. So we go from step 1, okay, so step 1, step 2 is in the same box. We go to step 3, we go to step 4, and then we go to step 5. Okay, so how do we start? So step 4 is as needed low dose ICS formoterol. So you probably can see here that the Ventolin, which is basically called as a short-acting beta agonist, is actually removed from the guidelines to treat asthma. This is a big change, right? So step 1 is as required low dose ICS format. So I've introduced ICS along with the LABA. So the SABA is gone. Okay, so we start from step 1, step 2, which is basically the same step. And then if patient is not responding, we go to step 3, which is basically we give this low dose ICS formoterol on regular basis. Okay, so it's not on as required basis, it's on regular basis on step 3. And then step 4, we increase the dose of the ICS. So the dose of the ICS is increased. And then step 5 is we add a LAMA, which is basically long-acting muscarinic antagonist. Okay, and then of course, like as step 5, we consider that if patient has severe asthma, which is a completely different category of asthma, and we consider the biologics, which are anti-IL-5 drugs, anti-IgE, and things on those lines. So it's really a combination of 𝐏𝐫𝐞𝐩𝐚𝐫 guidelines is move from step 1 to step 5. We can talk about it later on when we go through when we're doing the exam preparatory course, how to decide or when to decide when you're going from step 1 to step 3 or step 4 and so on. Very important table, moderate. So asthma, how to categorize moderate, severe, very, and then life-threatening. Many MCQs come in an exam in which they ask you that, is this moderate exacerbation? Is it severe exacerbation? Is it life-threatening exacerbation? So if you just focus on here that the peak flow expiratory rate, this is one of the main things. So 50 to 75% is moderate asthma. Okay, so we talked about COPD earlier on. So this is basically on the basis of the clinical symptoms and scenario when the patients come in, how to decide, because of course at that time, in that situation, an emergency situation, you don't have like pulmonary function test in front of you, so you go by these values in which you just check these values instantly, and then you can decide either this is moderate, severe, or life-threatening, because the treatment is actually different. Kind of like revolves around categorizing the asthma into moderate, severe, life-threatening. So if the peak flow expiratory rate measured by a peak flow meter is 50 to 75%, it's moderate. If it is 33 to 50%, it is severe. And if it is less than 33%, it is life-threatening, right? If the person can complete the full sentences, okay, it's moderate. If person can't complete sentences, it's severe. And of course, like, the life-threatening probably won't be able to spell the words. But and then you go on to the respiratory rate. Less than 25 is moderate. More than 25, it's severe. And then of course, above, obviously, like 30 or 35, whatever is it, like will be in the category of life-threatening. Pulse less than 110 is moderate. Pulse more than 110 is severe. And the life-threatening one, the main points here are the patients will be bradycardic or hypotensive or confused, or will have a silent chest. When you listen to the chest, there will be no wheeze. And if you do a gas on that patient, their pCO2 will be normal. Okay. And in this same scenario, there's one more class they're trying to introduce, which is called near fatal asthma. So this probably will be above the life-threatening asthma, and it actually says you might have a raised pCO2 in this, and hence it will indicate that you will require a mechanical ventilation. That means that you will be heading towards an ICU direction. Okay, so this is very important because the questions in MCQ, questions in exam, they kind of give you a scenario and then they say, is this moderate? Is this severe? Is this life-threatening? So it's very important. Okay, I just wanted to show you pulmonary function test in real life scenario. And this is a recent case I came across, and this is a full pulmonary function test which you can be lots of values actually to see. It's a very busy, this whole test there which you can see. So, but I will try to make it simpler. So there are three things you're gonna have to focus on. One is called spirometry. One is called lung volumes, and one is diffusion capacity. There are three parts of a full pulmonary function test. So spirometry, lung volumes, and diffusion capacity, which is also called gas transfer. Okay. In spirometry, so what we do actually is the whole patient's demographic, like age, sex, of course, like date of birth, and then smoking wise. So this man has 50 packet history of smoking. So it's very important to know. And then the BMI as well, which I don't have on this case. So you really start from, as I told you earlier, you start from FEV1 over FVC ratio. So you really start, so just start from this ratio. So what you can see here is 55%. So I told you 70% more, less. So it's less than 70%. What does it mean? So this is obstruction. So the first thing you know, this is obstruction. Next thing you want to know is either this is mild, moderate, severe, very severe. So where do you go? You go to FEV1, directly to FEV1. So what do you see? 50. So what did I tell you? That 80 or above, mild. 50 to 80 is moderate. So what is it? This is moderate because this is 50.25%. So you say obstruction, moderate. Next thing you check is, of course, asthma, COPD. So this part of the pulmonary function test is bronchodilation to check the reversibility. You give some extra puffs of Ventolin and you do the same thing again and check if this is reversible or not. So what can you see here? This FEV1 or FVC ratio is going from 55 to 65. So this is reversing, isn't it? So that means that this is not COPD because COPD is a fixed airway disease. And then FEV1 is going from 1.26 to 1.53. So see, this is reversing. So what is the criteria? So it's 12% and 200 mils. So you can see this is actually going to 21% as opposed to 12%. So is going above that, and then 200 mils as well. So basically you can see that this is asthma. So what will you say? This is obstruction, moderate, positive reversibility. And then the other thing you want to see next is lung volume. So any value on this all PFTs from 80 to 120% is normal. So that this range is normal range. So this is normal. Okay, a little bit less, but I wouldn't say we should be worried about too much because the FVC, which we have to coincide with TLC, is actually matching. So I don't think this should be a big issue in diagnosing. TLCO is the gas transfer. It's the only value which we have to look more when you see the diffusion capacity part of the PFTs, and it's 55%, which is low. So I would say obstruction, moderate, positive reversibility, reduced gas transfer, so consistent with asthma COPD overlap. You might be wondering why I've said COPD here. Now that is because that obviously the PFTs are not only the only thing which we have to see, but this patient had some emphysema on the CT scan as well. So in combining the radiology with the investigations, with the patient's history, we make a diagnosis. So this is where we diagnosed him as asthma COPD overlap. One more last thing I wanted to show you. This is the flow volume loop. This is very important in diagnosing patients as well, because normally the flow volume loop should be like this. It should be like this. Okay, this is the expiratory part, and this is the inspiratory part should be like this. But you can see that this is very obstructive. So it's going down, like see it's going down. So it means that there is airflow obstruction there. Okay, so this probably is the last thing I wanted to go with you guys, and this is basically some MCQs, just real exam MCQs, and we'll see just to kind of give you a taste of the exam. But I hope that you guys probably will do well. MCQ 1. A 65-year-old man with a 50-pack history of smoking presents due to increasing breathlessness. So the main things here are 65-year-old man, 50-pack history of smoking, and increasing breathlessness. Okay, a diagnosis of COPD is suspected. They are saying that we are suspecting that this man has COPD. Which of the following diagnostic criteria should be used when assessing a patient with suspected COPD? So which one of the following diagnostic criteria should be used when assessing a patient with suspected COPD? Okay, so there are 5 options. Okay, let's go through them together. So Option number 1, FEV1 more than 70% of predicted value plus the ratio less than 60%. Okay. Number 2, FEV1 over FEC less than 70% plus symptoms suggestive of COPD. Option number 3, FEV1 less than 70% of predicted value plus FEV1 over FEC ratio of less than 70%. Option 4, FEV1 less than 80% of predicted value plus FEV1 over FEC ratio of less than 60%. Option 5, FEV1 less than 70% of the predicted value plus FEV1 over FEC ratio of more than 70%. Now, I think how should we solve the MCQ is we should actually try to see which ones cannot be the answer. So this cannot be the answer because this is more than 70%. It cannot be the answer because it has to be less, the ratio has to be less than 70%, right? So that leaves us to these scenarios. This can be there, this can be there, this can be there. Okay, now we go to next to the FEV1. Okay, so this one cannot be the answer because this is more than 70% of the predicted value. Okay, we probably are going to narrow down to see what the diagnostic criteria is. So the diagnostic criteria should involve the symptoms, which is very important. So the only answer here has symptoms suggestive of COPD. So the answer is number 2. So what is the correct answer? The correct answer is the ratio is less than 70% plus symptoms suggestive of COPD. As per NICE guideline, the diagnosis of COPD requires both the presence of symptoms, which are breathlessness, cough, sputum, wheeze, and airflow obstruction on spirometry. So you need to have both. So you have symptoms plus the investigations which show ratio of less than 70%. The key spirometric criterion for COPD is a post-bronchodilator FEV1 over FEC ratio of less than 70%. The FEV1 value alone is used to grade the severity of COPD once the diagnosis is established, but is not part of the diagnostic criteria. Okay, MCQ number 2. A 20-year-old girl attends the emergency department with a 4-hour history of shortness of breath on a background of asthma. She was treated with oxygen, intravenous magnesium. Here you can probably understand that probably looks like quite severe asthmatic attack, but somebody is requiring intravenous magnesium. And ipratropium salbutamol, which is a LAMA-SABA nebulizer on admission. Despite her treatment, her respiratory rate is despite giving that all, her respiratory rate is above 35 per minute. Saturations are 93%. Heart rate is 112 per minute. And temperature is 37.3, which is normal. Her peak flow expiratory rate, which is very important, is 40% of the predicted. On examination, she cannot complete sentences. These are very important lines. And there is a widespread wheeze or auscultation. So the blood gas is shown. Let's go through it. So the pH is normal, 7.37. So the normal ranges are given in the exam. So it's within the normal range. PaO2, which should be PaO2. So it's arterial oxygen, is 10.1. So you can see that is within the normal range because more than 9 is normal. PCA2, 4.9, again normal. So normal pH, normal pH, normal PaO2, normal PCO2. Okay, base excess is okay, and lactate is okay. All right. So they say which of the following is this asthma can be categorized into either it is severe, life-threatening, mild, moderate, near fatal. So if you can recall, I showed you the classes. So I think the correct answer here should be severe because there are a few things. So one is can't complete sentences, right? Peak flow expiratory rate 33 to 50%, and you can see that her peak flow expiratory rate is 40%. It is falling between in this value. And then the respiratory rate is 25. So here respiratory rate is how much? Is 35. So most of these are fitting into the criteria of the severe. So the answer is severe, right? So that hence this is very important to remember. Okay, let's go to another question. Which one of the following is the main criteria for determining whether a patient with COPD should be offered long-term oxygen therapy? So this is actually called as LTOT. This is called long-term LTOT. So this is long-term oxygen therapy, right? So let's see. So what are the options? Number 1, 2 ABGs or arterial blood gases with PaO2 of less than 6.3 kilopascals. Number 2, one arterial blood gas measurement with PaO2 of less than 7.7 kilopascals. Number 3, one arterial blood gas measurement with PaO2 of less than 8.3 kilopascal. Number 4, one arterial blood gas measurement with PaO2 of less than 8 kilopascal. And number 5, two arterial blood gases measurement with PaO2 of less than 7.3 kilopascals. So really, the thing to remember here is actually to focus on these words. Two arterial blood gases, one arterial blood gas, and then again the values. So you have to remember this value, 7.3 kilopascal, 7.3 kilopascal to 8 kilopascal. These are the values to remember here. So anything below 7.3 is very important. Or if you have a value in between 7.3 to 8, that is also important, but we have to put into the clinical context, right? So what's the answer here? Okay, so the guidelines say two arterial blood gases of less than 7.3 is telling us that this patient will need long-term oxygen therapy. So BTS guidelines say that LTOT should be offered to patients with COPD who have PaO2 less than 7.3 kilopascal in two separate measurements taken at least 3 weeks apart. It's very important. Two separate measurements taken at least 3 weeks apart when the patient is stable and receiving optimal medical management. So it's not just we do a blood gas and the PaO2 is less than 7.3 and we say, look, this patient is suitable for long-term oxygen therapy. It's not like that. The guidelines say that you need to have two separate measurements taken 3 weeks apart. And then you need to say this patient is suitable for LTOT. So the answer is number 1. All right. Okay. So a little bit about long-term oxygen therapy. Patients who receive long-term oxygen therapy should breathe supplementary oxygen for at least 15 hours a day. This is very important. Somebody can ask in the exam. So long-term oxygen therapy, supplementary oxygen therapy for at least 15 hours a day. Okay. Assessment. When do we need to consider somebody for LTOT? So if somebody has very severe airflow obstruction, FEV1 of less than 30%, as I told you earlier, assessment should be considered for patients with severe airflow obstruction or they have severe airflow obstruction. So less than 30%, as I've told you, is very severe, and 30 to 50 is severe. So severe airflow obstruction. Number 2, cyanosis. Number 3, polycythemia. Hemoglobin is up. Number 4, peripheral edema, raised JVP. Number 5, oxygen saturation is less than or equal to 92% on room air. And then the next thing is who you can offer. So offer means that you are going to give the long-term oxygen. So give long-term oxygen therapy to patients with PaO2 of less than 7.3 kilopascal, as I've told you earlier, measured at two separate occasions 3 weeks apart, or to those with PaO2 of 7.3 to 8 kilopascal and one, this is very important, and one of the following. So somebody has PaO2 of 7.3 to 8 kilopascal, they need to have one of the followings along with it in order to be given LTOT. So one is nocturnal hypoxemia. Number 2, secondary polycythemia. Number 3, peripheral edema. Number 4, pulmonary hypertension. So the MCQs, when they come in the exam, they can actually say you a patient has a PaO2 value of, let's say, 7.35 and has one of the followings. Which one of the following is most important? So one of these 4 will be the one to choose the answer as. Okay. So nocturnal hypoxemia, secondary polycythemia is very easy to remember. Hypoxemia, polycythemia, and then peripheral edema and pulmonary hypertension. Okay, let's do another MCQ. A 72-year-old man presents to ED with 1 year history of dyspnea. So 1 year history of dyspnea. That's very important. 1 year history of dyspnea and accompanying dry cough. He has never smoked. So never smoked. Has history of rheumatoid arthritis. That is very important. And currently being treated with methotrexate. Very important. So he's on treatment for rheumatoid and has no documented history of allergy or atopy. So the question is actually telling you it probably is not asthma because there's no documented history of allergy. It's probably not COPD. because 90% of the COPD is because of smoking. So that means if you look at the answers here, you already have actually crossed out asthma. Okay, and on examination, an expiratory wheeze is noted. The following results are obtained from spirometry. So the ratio is 60%, which means this is obstruction, right? What is the most likely cause of his symptoms? Okay. Sorry, can you mute? Sorry, can you mute in the background? Thank you. What is the most likely cause of his symptoms? Okay, let's see. So the answer here is because of the fact that this patient has rheumatoid arthritis, right? And he's breathless for a year. The main thing to remember here is bronchiolitis obliterans is associated with someone who has rheumatoid and has symptoms. So the patient's history of rheumatoid arthritis with symptoms of dyspnea, cough, wheeze, an obstructive pattern on the spirometry strongly suggests bronchiolitis obliterans. Easy. Obstructive pattern spirometry is evidenced by decrease in ratio I've told you earlier. So this condition is recognized as one of the pulmonary complications associated with rheumatoid arthritis. So when you're doing the exam, you just have to focus on the main key things which are written in the exam scenario, in the question, and you just eyeball the answers and you know what the answer is, rather than just individually going through the options. Okay, let's do another MCQ. You are reviewing the management of a number of patients with COPD. Which one of the following factors should prompt an assessment for long-term oxygen therapy? So this is one of the things I told you earlier, that which one of the following things can tell you that we should be looking for assessment for long-term oxygen therapy. So FEV1 of 54% of predicted. I think this should be FEV1 54% of predicted, hemoglobin of 18.1 gram per deciliter, BMI of 18, oxygen saturation of 93, it's not 92 because 92 and less is important, 93, and a ratio of 0.47. Okay, so here the answer is hemoglobin of 18.1. Why is that? Because this is secondary polycythemia, which I've told you earlier. A significantly raised hemoglobin level polycythemia in a COPD patient suggests chronic hypoxemia and should prompt an assessment for long-term oxygen therapy. And why this secondary polycythemia develops is because of the chronic hypoxia in COPD patients, the erythropoietin, which is made by the kidney, is raised, and leading to increased red blood cell production to improve oxygen delivery to the tissues. Okay. This is probably one of the last slides. I just wanted to show how important the pulmonary function tests are in your real clinical life as well. So if you actually look at this, again, the same thing again, 3 parts: spirometry, lung volumes, gas transfer, or diffusion capacity. The values here are FEV1 over FVC ratio is 70%, more or less is more. So that means that it could be restriction, but we go to FEV1, so 80 or more than 80. So more than 80, which means that it looks to be normal to me there within the normal range. FVC is 92%, which is also within the normal range. So normal spirometry, okay. 80 to 120 is the normal range. So both values are between 80 to 120. So normal lung volumes, diffusion capacity 80 to 120, normal diffusion capacity. The main thing, if you look here, is the flow volume loop. And as I told you earlier, normally the flow volume loop should be like this. And you can see here the inspiratory and expiratory limbs both are actually very narrowed like this. This is a very typical scenario of someone who has a fixed airflow, a fixed intrathoracic airflow obstruction. So normal spirometry, normal lung volumes, normal gas transfer, flow volume loop consistent with fixed airway obstruction, and this patient had a tracheal tumor. He had a tracheal mass there when we did the bronchoscopy, and it has a tracheal tumor. So basically, this is very important. Is this flow volume loop, which obviously we will go into detail once we do the exam preparatory course. So this is basically a fixed airway obstruction flow volume loop. Okay, so this is where I conclude today. Thank you for attending and listening to me, and I hope you guys will join our upcoming preparatory course, and we will together aim to exceed and excel in the part 1 in August, and hence go towards part 2 and so on. And this is my conferring ceremony. And nothing in life is to be feared, it is only to be understood. Now is the time to understand more so that we may fear less. I'm happy to answer any questions if you can put them in the chat box. Thank you.
Hmm. Sir, any learning resources as of now?
Okay, yeah. So learning resources wise, they're standard exam MCQ banks, such as when I say standard, I mean they are pretty helpful, but such as past medicine, past test on examination, but you need to have a mentor, a person with the topics. If you start to study, I think medical knowledge is so vast that you probably will be just be spending a month, let's say, on cardiology or another month on gastroenterology. I think the question banks are helpful, but they are not the ultimate things to rely on in order to pass the exam.
Thank you, sir.
Any other questions?
Sir, if facing any questions, can an additional question be asked, sir?
Yeah, go ahead. Yeah, why not?
Yeah. So, to say frankly, sir, I'm an emergency medicine student in India, sir. So, I have to clear my boards here, then go for that or parallelly. That's why I said, meanwhile, go with this, then join a mentorship program. After I complete it in May, sir, theory exams. Yes, sir. So, only I got in touch with MRCEM of this expert group, sir. Then this Zoom meeting I attended. So, how can it be planned, sir, for a guy like me, sir, who has completed a training program in India, but not cleared the boards as of now, sir?
Sorry, so I didn't get your question. You're asking
Yeah,
how to.
yeah. Sir, I have completed a training in emergency medicine, sir, but I don't have held a degree here, sir. But also wishing to join MRCPI course, sir. So how better it will be to join early or to clear the exam, then join the mentorship program, sir?
Yeah, I suppose it's obviously individually based timeline. So if you are aiming to give your, let's say, part 1 exam in August of this year, I think it will be April would be a good time to join the program, because I think the way I will, in collaboration obviously with MedExam expert, design the program will be that it will be lectures and topic based. Along, obviously, in the background, you guys will be doing your MCQ preparation as well. And of course, I do understand. I did this myself, along with our daily day-to-day job, which obviously is very hectic. But I think the main thing is if you aim to set up a time period, a timeline of at least, I would say, 3 months, along with your day-to-day job, plus joining a good mentorship program, I think you should be able to excel the part one exam. It's doable.
Thank you, sir. Thanks a lot for motivation, sir. Inshallah, sir. The April, I will set it as my target, sir, to join. Inshallah, sir. That's what I could get, sir. Yeah.
Thank you.
Thank you, sir.
Someone is asking ideally how much time is required for preparation. That is I've already answered. I think 3 months, along with the obviously joining a good mentorship program is sufficient. What is the schedule of med exam expert for preparation course? We will be releasing our schedule soon. Along with the rest of the team. But I think we are starting in April for the August date of MRCPI Part 1. And of course, if anyone has questions related to getting the subscription or entering into the into this program, into this course, I think they have posted the links, and any questions you can ask directly to the med exam expert in regards to the subscription fee and structure. Another person has asked, will you be discussing MCQs from the question banks too in the program? Well, of course, I think my main goal is to make sure that all of my students pass the exam. Of course, and how to make it possible is that I will try to make it as simpler and as easy as possible. Um, People do fail in the exam, but failure is not something we shouldn't learn from. I think if you fail, you actually are learning. So I think the main thing would be to keep yourselves motivated, and um, do do it every day. What I mean to say is try to study and try to revise it every day. I will be posting MCQs, and we will be discussing the answers on the platforms as we go along with the lectures which I will be delivering. And it's really the course material which I will be discussing with you guys will be inshallah will be very helpful in order to obviously give the exam, and of course in your day-to-day practice as well. What is the passing percentage of the part one exam? I'm not 100% sure on this, but what I can tell you is that it's 100 MCQs, 3 hours. There's no negative marking. Most of the MCQs don't have very lengthy stems. They're short. Sorry, they're short stems. Um, I can't tell you a percentage. You might be able to find it on the RCPI website, but in my experience, candidates pass it once they have a lot of revision and of course good mentorship in their background. MRCP versus MRCPI passing, sir. Not sure about it, but what I can tell you is it doesn't really depends that people are appearing internationally or nationally. Each question carries equal marks. It really just depends on obviously how better you perform. MRCP versus MRCPI, which one is easier? I gave both. I I cannot say which one is easier, but what I can tell you is you can probably imagine yourself. MRCPI Part 1 is 100 MCQs, whereas MRCP UK Part 1 is 200 MCQs. It's a two-part exam that you have to give 3 hours, whereas Part 1 MRCPI is a 3 hour exam. A bit tedious to give Part 1 UK. But I think probably both are the same, in terms of, I can't say which one is more easier, but you need to have like that level of knowledge in which you feel comfortable and confident to answer the questions. Can we practice as a trainee doctor after passing whole part two exam? Well, I suppose when you say a trainee doctor, you mean to say in Ireland, if you're talking about. So, a trainee doctor in Ireland actually is giving the exams, like when you enter the BST training. Passing MRCPI is a part of the BST training as a 2 year program. So passing the MRCPI is not eligibility criteria to enter into the BSc training, if you know what I mean to say. But you can get more information from the online RCPI website as well. But this is my understanding anyway. Chances of getting BST in Ireland increase if you have completed MRCPI? The answer is yes. Um, but it's not eligibility criteria, but yes, the chances increase because obviously you are going to interview. It's a proper interview panel, and you're competing with other candidates. In whatever way your CV is stronger, you will be placed higher than the candidate. So the answer is yes. Okay, so we probably have to finish here now, and I hope that was helpful for you all, and I hope to see you soon, and have a good day. Thank you.